Good morning to you. Thanks for the organizing committee for the kind invitation. So my talk will be a continuation of what Dr. 𝗘𝗴𝗆 presented, and also a continuation of Mr. 𝗟awad's presentation. The popliteal artery represents a specific region that has a lot of challenges because of the anatomical space that it is sitting in. It is exposed to excessive and repetitive forces, the biomechanical forces, and it is affected by the inflow characteristics and also by the outflow characteristics because of the trifurcation, and frequently we find in those cases that it's one or two or three vessels are affected, and that also reflects on the management of or the intervention for the popliteal artery. For this talk, I will only talk about the atherosclerotic occlusive disease. I will not talk about the cystic adventitial disease or the entrapment or the aneurysm affecting the popliteal artery. There isn't, because of the complexity of this area, there is no one size that fits for all, so a lot of options. So I'll present a few cases, and each one has a message behind it. This is a case presented with P3 total occlusion, and also there is occlusion of the proximal part of the posterior tibial artery, and there is just a ghost of the peroneal artery. This was intraluminally revascularized, and that's my usual approach. It's slightly different from David's approach, but I try to, especially in the popliteal area, I try to stay intraluminal as much as I can, because if I go subintimal, I'm not so sure that I can get back because of the outflow vessels. So I went into the peroneal and also into the posterior tibial artery, and with prolonged ballooning, I got good results out of this. Now, this area of the trifurcation, Rida has mentioned or touched on it. It's a quite complicated one, and surgery traditionally has been the treatment or the intervention of first choice. This is a paper of 108 patients with comparing open versus endovascular, mainly focusing on the lesions in the trifurcation. The technical success between the open versus the endovascular was 100 versus 96%, so it's quite high technical success in both modalities. Freedom from major events in the limb was almost equal, not statistically different, 77 versus 68 between open and endo. The early mortality was much higher in the open surgery, but the overall survival was not significantly different. The reintervention rate was significantly higher in the endovascular option. And I tend to agree with the final conclusion of Mr. 𝗟awadh that open, generally speaking, gives better results than endo in those territories. There's another case with a total occlusion of P3 and a single run-off vessel. As again, single run-off vessel, it's quite severe, or high-risk patients, because you could lose even the open option if you trash it badly. This case was, again, intraluminally recanalized, and because I got suboptimal results from the angioplasty in the popliteal, I put superior stent with good results. There's another case with also total occlusion of the P3 and the sort of P2 as well, and that's also because of the suboptimal results post-angioplasty, and I tend not to leave any suboptimal intervention, because that means even if everything is running, the lesion will go down soon. put a 𝗔𝗴𝗆 stent with good results. The 𝗔𝗴𝗆 stent, generally speaking, has very good results. The primary patency at 12 months in several publications is approaching 90%, and the low incidence of fracture. It's only case reports of fracture. And this area was famous of fracturing stents, the popliteal artery. 𝗔𝗴𝗆 is not the only stent. 𝗔𝗃 is another option. These data from the French registry, 98 popliteal lesions. The mean lesion length was around 90 or 9 centimeters. The primary patency rate was at 24 months just inferior to the 𝗔𝗴𝗆, 67%, but the secondary patency rate equivalent to 𝗔𝗴𝗆 of 99%. There's another lesion which involves the trifurcation, but the lesion here is heavily calcified, and it's almost 99% plus occlusion of the tibioperoneal and 90% or more than 90% occlusion of the anterior tibial artery. It's an ugly lesion, heavily calcified. When I did the case, I didn't have access to lithotripsy. This was treated with putting kissing wires, recanalizing both vessels, the ATA and the tibioperoneal. And because I didn't get good results with the plasty, I put drug-eluting stents in both as kissing stents. This area either can be stented with kissing stents or using the Y sort of technique that you go through the mesh of a stent and stent the other limb. Why I use drug-eluting? Because that's what was available, and it's a coronary stent, and it gives good results, and it's of a good size. It's 3.5 millimeter. There's another lesion. Again, it's a single run-off vessel, another nerve-wracking lesion. Those lesions, we have a very good team, surgeons and interventional radiologists. We have very good surgeons, and those cases, yes, the preferential choice is open, but frequently those patients are not suitable for open for one reason or another. And because it is single vessel, although I got good results, but I usually tend to use drug-eluting balloon because, again, it's a single runoff and I can't afford to lose it. So I tend to use drug-eluting balloon, although the evidence for drug-eluting in the infrapopliteal is not well established. There's another case, focal lesion, tightly stenosed, 90 plus stenosis. It's calcified, although you don't see the calcification, but it is calcified lesion. It's a quite focal. I treated this with atherectomy with good results. These data from the Vascular Quality Initiative from the American Registry of 2040 patients comparing stents, angioplasty, and atherectomy, and it showed that the primary patency is in favor of atherectomy, but there is no difference in comorbidities. Atherectomy is a good device, but it has potential of distal embolization, and it's not good for very long lesions. There's another case, very heavily calcified, more than 90% stenosed, treated with lithotripsy with good results. The published results from lithotripsy, there's a systematic review published this year of 769 lesions, and the stenosis reduction is is around 60% with very low complication rate. And the conclusion was it is safe, effective, but needs more data to establish its role. There's another case, quite complicated. It's not only popliteal, but also the inflow. I couldn't anterogradely recanalize it, so I used this Farah technique and came from the posterior tibial behind the ankle and established the antegrade and retrograde approach with good results. So to conclude, I'm going out of time, the plan has to be tailored to the patient's anatomy and the patient's general condition. I prefer to stay intraluminal as much as I can and avoid distal embolization, do everything to avoid distal embolization and trushing. I tend not to leave metal behind if I can, and try to optimize the lesions treatment, and also don't forget the inflow and outflow optimization. Thank you very much.